Hello, everybody. On behalf of IVF Worldwide members, I have the pleasure to host today Dr. Caroline Roelens. Caroline is working as a clinical fellow at the Center of Reproductive Medicine, the University Ziekenhuis, Brussels, Belgium, and she is preparing a PhD thesis about optimization of frozen embryo transfer cycle. Her presentation today is about progesterone supplementation, effects and optimization of duration on live IVF ICSI birth rates and FET cycles. Caroline, please.
Thank you very much for this kind introduction. So the content of this presentation will be, I will talk first about the role of progesterone, then I will go on with a little short introduction on implantation. I will talk about luteal phase deficiency in IVF, and then luteal phase support in IVF and frozen embryo transfer cycles, and I will end with some conclusions. So if we look to the role of progesterone, so progesterone is the major hormone produced during the luteal phase. It induces secretory transformations of the endometrium and will indeed also lead to decidualization and will prepare the endometrium for embryo implantation. But progesterone also has immunomodulatory effects. It will also lead to an increase in nitric oxygen production, which will lead to a local vasodilatation and uterine musculature relaxation. This latest is important because an inadequate musculature relaxation can lead to extrauterine pregnancies or miscarriages. And another important role of progesterone is, of course, pregnancy maintenance, because all studies from SASPO, we see that if we remove the corpus luteum, which is in fact the major producer of progesterone, before 7 weeks of gestation, it leads to a pregnancy loss. If we supplement this loss of progesterone with exogenous progesterone, then we see that the pregnancy will maintain. If we go a little bit deeper into the immunomodulatory effects of progesterone, it has been accepted that progesterone will lead to a shift in T helper cell 1 pro-inflammatory cytokine production to a T helper cell 2 anti-inflammatory cytokine production. And this effect is being driven by progesterone-induced blocking factor. But of course, these very difficult immunomodulatory changements which are occurring when an embryo implants, well, this paradigm is not enough to explain it. And if we look to the picture on the right side, well, we see, and this is a proposition of some effects of progesterone, which has been shown in murine models, which needs to be confirmed in humans. This was a paper from Griesinger, which was published in 2018. We see that progesterone will lead to a local, but also a systemic rise of T regulator cells, which are also helping in this immunoregulation. It will also lead to arrested dendritic cells in a tolerogenic state, and this is also driven by immunosuppressive molecules like galectin-1 expression. And there, apparently, progesterone seems to play a role to allow this semi-allogenic embryo to implant in the endometrium. If we look to pregnancy maintenance, well, the two major RCTs which are published in this field are, of course, the PROMISE trial, which is progesterone supplementation in early pregnancy in patients with recurrent miscarriages, and the PRISM trial, which is a progesterone supplementation in patients with a spontaneous miscarriage or a threatened miscarriage, patients with blood loss, for example, in the first trimester. Well, both studies failed to show any favor for progesterone use in all patients, but what was interesting is when we look to the subgroup analysis, is that patients with a higher number of previous miscarriages are benefiting more from progesterone supplementation. As well in the PROMISE trial as in the PRISM trial, here we see in the PRISM trial that from three previous miscarriages onwards, that there is an advantage of using or giving progesterone to the patients. And why is that? Well, if we look to the figure on the left side, we see that with the number of previous miscarriages, well, the risk of aneuploid miscarriage is stable, but from 4 miscarriages onwards, we see that there is an increase in euploid miscarriages, and there probably the luteal phase effect can play an important role. And these are the patients which can benefit from progesterone supplementation. And on the right side, you see, in fact, all the RCTs which are performed in the field of progesterone supplementation in early pregnancy in as well threatened and recurrent miscarriage. And if we see the conclusion, well, we can see that in patients with threatened miscarriage and recurrent miscarriage, that there can be a place for progesterone, but of course in a selected group of patients, for example, patients with an amount of miscarriages in the past. If we look to the human corpus luteum, well, it's a temporary endocrine organ which transforms from the granulosa in the theca cells during or after ovulation and during the luteal phase, and it's driven by LH. It's active during the luteal phase and also early pregnancy until approximately 8 weeks of gestation. And the major products of secretion products from the corpus luteum is, of course, progesterone, estrogen, but there are also some other factors which are produced by the corpus luteum. And for example, the vasoactive substances, relaxin and vascular endothelial growth factor, are gaining more and more attention in the latest years. Why? We see, for example, in HRT cycles, in frozen embryo transfer cycles, so hormone replacement therapy cycles, that there is an absence of a corpus luteum and that they have a higher risk of hypertensive disorders of pregnancy. And that can probably be linked to the absence of vasoactive substances, which are important for the maternal adaptation and also for the placental invasion. So what about implantation? Well, progesterone seems to be a natural timer for the opening and the closing of the window of implantation. And it's the timing of the onset of reaching a certain threshold, which is more important than the mid-luteal progesterone levels. So if we look to implantation, we have two major players. We have the endometrium at one side with an optimal window of implantation, and we know that implantation is possible during a 4 to 5 day window, but is probably only optimal in a 2-day window. We have the receptivity of the endometrium, which allows the endometrium to make a nice environment for the embryo to implant and later onwards for placental development, and the selectivity of the endometrium, which is the ability of the endometrium to select and also reject embryos with the developmental potential which is not good. For example, aneuploid embryos which are recognized and which the endometrium does not allow to implant. And on the other side, we have the embryo, and there, of course, the embryo quality is important. The aneuploidy rate, as I said before, which will increase with an older age. The developmental stage of the embryo, so we know that cleavage stage and blastocyst needs to be transferred on a different time, and the blastulation rate, which can be lower in older patients and poor responders. If we look to the study of Franasiak, at the left side, we see a natural conception. So we see that there we have the onset of the LH surge and the ovulation, which occurs approximately 24 hours later. And this ovulation goes ahead with the progesterone rise. And it's the progesterone which will determine the opening of the endometrial window of implantation. And in a natural conception, there is a synchrony with the embryonic window of implantation. But what can happen in controlled ovarian stimulation, that is the figure that we see on the right side, is that the progesterone rise can already occur earlier than the oocyte retrieval. And this gives a shift of the endometrial window of implantation to an earlier opening. And if then we don't adapt the embryonic window of implantation, we see that there can be an asynchrony, certainly with embryos or blastocysts, for example, who have a later blastulation rate. In older patients or poor responders, they can fall out this endometrial window of implantation and they will finally not implant. So why do we need progesterone supplementation in IVF cycles? There are some theories. So first of all, maybe the granulosa cells, which are the driven factor of progesterone production, can be damaged or removed during an oocyte retrieval. Is it maybe because of GnRH agonist or antagonist treatment, or is it an HCG-induced suppression of LH, HCG, which is used for final oocyte maturation? Or is it the supraphysiological steroid levels in the late follicular or the early luteal phase, which are suppressing LH, which we see in the figure that estrogen can can inhibit by a negative feedback the anterior pituitary and lower the LH production? Or is it maybe a combination of different factors? Well, let us see to a few studies. First of all, this is a study by Jones, which is showing that in hyperstimulated cycles, so controlled ovarian stimulation, we encounter higher progesterone concentrations in the luteal phase, but also an early luteolysis. And so we see, compared to a natural cycle, that we have a luteal phase gap. And it's that gap that we need to cover with exogenous progesterone supplementation. And this was a nice study performed by Beckers showing different situations. So the first graph is just the natural luteal phase. The second one is an agonist protocol followed by HCG trigger and HCG as luteal phase support. So we remark the high progesterone levels, but they remain until day 14 as in a natural cycle. But if we look in the lower graph, we see that if we don't use any luteal phase support, that in fact, the progesterone concentration is already decreasing from day 8 after HCG trigger. And that is because of the fact that the duration, the half-life of HCG is around 7 to 10 days. And afterwards, well, the corpus luteum is not stimulated anymore to produce any progesterone. So we need, in fact, luteal phase support in agonist cycles. On the other hand, we can ask, why do we need luteal phase support in antagonist cycles? Because we know that after cessation of an antagonist, approximately 24 hours later, the gonadotrophin secretion will again retake place. Well, in this study, where 3 different ovulation triggers were used, first of all, HCG, second phase, recombinant LH and GnRH agonists, and we see that in the 3 situations, well, luteal phase support is needed because the progesterone concentrations are lowering earlier than day 14 of the luteal phase. And so, in fact, from this study, we can conclude that probably the luteal phase deficiency, which is encountered in agonist and antagonist cycles, is principally related to the supraphysiological steroid levels in the late follicular and early luteal phase, which are inhibiting DLH secretion. So progesterone is recommended for luteal phase support. That has been shown in this Cochrane review by van der Linden et al. So we see that different studies were looking at live birth rate and ongoing pregnancy rate, and we see that there is a benefit in favor of progesterone use. Why is progesterone chosen above, for example, HCG? Well, this has been shown in this study, also the Cochrane review of van der Linden, where we see that progesterone and HCG are compared, and we see that a higher risk of OHSS is occurring when we are using HCG. And that is the reason why progesterone is the #1 luteal phase support in IVF. But when do we need to start this luteal phase support? Well, the ESHRE recommendation is that we need to start it between the evening of the day of oocyte retrieval and day 3 post-oocyte retrieval. If we look to this review by Connell, we look at different studies comparing different initiation times of progesterone. And what was the most striking was that when we start 12 hours before the oocyte retrieval day, we see that it was associated with significantly lower clinical pregnancy rates. And if we look day 3 or day 6 starting after oocyte retrieval, that if we start progesterone day 6 after oocyte retrieval, that there is also significantly less clinical pregnancies. That is why we conclude that we don't need to start the luteal phase support before oocyte retrieval and not after 3 days post-oocyte retrieval. This was a more recent study, an RCT, comparing starting luteal phase support the evening of the oocyte retrieval or the day after. There was no significant difference in live birth rates, neither in progesterone concentrations on the day of ET, so we can start safely the evening or the day after the oocyte retrieval day. So there are a lot of progesterone administration routes, and in fact all the routes can be used, because in this web-based survey, on the other hand, we see that vaginal progesterone is still in Europe the most used administration route. In North America, we have as well vaginal as intramuscular progesterone, which is very popular. But indeed, in this Cochrane review, different treatment regimens of progesterone were compared, and there was only one study, one comparison, which was comparing intramuscular and vaginal progesterone, where there was a favor for intramuscular progesterone, but all the other studies failed to show a benefit of one administration route in preference to another one. So I will just shortly go over the Lotus 1 and Lotus 2 trials. So oral dydrogesterone, oral progesterone in luteal phase support, 2 randomized controlled trials comparing oral dydrogesterone and micronized vaginal capsules and gel. And we saw that there was non-inferiority of oral dydrogesterone as a luteal phase support in IVF. And that can offer maybe a more patient-friendly route compared to micronized vaginal or intramuscular progesterone. There were some concerns, although, about the safety, but if we look to these 2 comparisons, Lotus 1 and 2, we see that there was no significant impact on congenital, familial, and genetic disorders that could be evaluated. When do we need to stop the luteal phase support in IVF? Well, it should be administered at least until the day of the pregnancy test. So this is just a short reminder that from old studies, we have seen that the luteal placental shift is occurring approximately around the 6 to 8 weeks of gestation, but already from the 5th and maybe already earlier, there is some progesterone production by the placenta. So if we look to this study meta-analysis of Liu et al., he was comparing different strategies of stopping the luteal phase support in IVF. And if we look to live birth rate, there were 2 studies comparing stopping the luteal phase support 14 days versus 7 weeks pregnancy, or 11 days post-TT versus 6 weeks, and we didn't find any significant difference. Neither was the case in miscarriage rates, so different studies comparing different stopping times of luteal phase support, and also in ongoing pregnancy rate, there was no difference. So we can conclude that in fact the luteal phase support can be discontinued once a positive HCG is detected. But again, if we look to this web-based survey, we see that in general practice, well, the luteal phase support is continued much longer. And as Liu said in his meta-analysis, a lot of centers are saying we want to be better safe than sorry. So this is just a short recommendation to the different administration routes, so the dosing of the different administration routes, and just a study to show that if we, for example, measure mid-luteal progesterone levels in fresh IVF cycles, well, this was a study measuring the progesterone 7 days after ET. Well, if we higher the dose of progesterone, if the progesterone concentration was under 15 nanograms per ml, we see that there is no significant difference in live birth rate. Although what the study showed was that mid-luteal levels of progesterone under 17 nanograms per ml were associated with lower cycle outcomes. So let us go now a little bit deeper in the frozen embryo transfer cycles. So we have different frozen embryo transfer cycles preparation methods. So first of all, we have the natural cycle with a true natural cycle with a spontaneous ovulation, or a modified natural cycle where HCG is used to trigger the ovulation. We have ovulation induction cycles where clomiphene citrate, tamoxifen, letrozole, or gonadotrophins are used in order to induce follicular growth. And then worldwide, the most used preparation method is the hormone replacement therapy cycle, where exogenous estrogen and progesterone are administered, all or not, in combination with an GnRH agonist. If we look to the figure at the right side of the presentation, this was published in a review of Mackens. Well, there we see that it's very important to speak the same language. Of course, blastocysts and day 3 embryos needs to be transferred at the same time, at a certain time, not at the same time, but at a certain time point in the cycle, to avoid, in fact, problems with the window of implantation. And in an HRT cycle, well, we start with estrogen supplementation until the endometrium reaches 6.5, 7 millimeters triple line structure. And then, in fact, on the theoretical day of oocyte retrieval, we start with progesterone, and then day 3 embryos are transferred 4 days on the 4th day of progesterone supplementation, and blastocysts on the 6th day. After HCG trigger, well, we see that 36 hours later, the pickup normally will occur, and then 3 days later, so 5 days after the HCG trigger, and a cleavage stage transfer, and 7 days later, a blastocyst transfer. For the LH search, we know that there the oocyte retrieval or the ovulation will occur 24 hours later, and that is the reason why we are transferring cleavage stage and blastocysts 1 day earlier compared to the HCG trigger group. So, in fact, the Cochrane review of Gobara of 2017, well, they didn't find any evidence to support the use of one cycle regimen in preference to another one. So, although fed cycles are becoming more and more important, we don't know which protocol is the best to use. So what about progesterone then in frozen embryo transfer cycles? Well, in natural or modified natural cycles, we see from all studies that approximately 8% of the normal ovulatory patients have a luteal phase defect, and these are probably the patients who can benefit from progesterone in the luteal phase. The question is still, when do we need to start? And if we look to different studies, well, no significant difference was seen in clinical pregnancy and ongoing pregnancy rate in true or modified natural cycles. This is a retrospective study performed at our center comparing different treatment regimens, so managed natural cycle with luteal phase support, a natural cycle with luteal phase support, or a natural cycle without anything. We see that there was a trend towards a better outcome in the complete natural cycle, but if we look to the mixed effect multi-level model, we see that the odds ratios are also in favor of the natural cycle, complete natural cycle without progesterone supplementation. And if we then look in HRT cycles, of course, in hormone replacement therapy cycles, progesterone supplementation is mandatory because there is no corpus luteum, so there is no endogenous progesterone production. But here also we see that comparing different administration routes don't give any difference in live birth rate, clinical pregnancy rate, or multiple pregnancy rate. This was also still an ongoing RCT comparing 3 different treatment regimens: intramuscular progesterone compared to micronized vaginal progesterone, together with intramuscular and micronized vaginal progesterone alone. Due to the high overall pregnancy losses in group C, well, this group was unblinded earlier, and it seems to be that this group was the micronized vaginal progesterone group. But what we need to say is that, of course, the dose of micronized vaginal progesterone in this study was quite low, and normally we are using 600 to even 800 milligrams a day in frozen embryo transfer cycles. So probably the underdose can be a reason of the overall higher pregnancy loss in these cycles. And what about the start of progesterone? Well, in donation cycles, it has been shown that for cleavage stage embryos, higher pregnancy rates were obtained if progesterone was started at the oocyte retrieval day or the day after. But for blastocysts, starting 1 or 2 days before the oocyte retrieval was not accompanied with a lower outcome. And then the last part, the progesterone, the duration of progesterone supplementation before transfer. Well, a few studies in our center were performed. This is the first RCT comparing transfer of day 3 embryos, which in our center are taught at day 3 but transferred at day 4. If we compare transferring these cleavage stage embryos on the 3rd or the 5th day of progesterone, well, no significant difference was seen in terms of live birth rate, but look at this high early pregnancy loss in the 3 days group. So probably there is not enough progesterone supplementation yet, and only impaired embryos can here implant in this situation, leading to pregnancy loss. The same group also performed that study for blastocysts comparing transfer of a blastocyst on the 5th or on the 7th day of progesterone supplementation. Again, no significant difference in outcome. But a big remark on this study was why we were not comparing with the golden standard, which is in fact transferring blastocysts on the 6th day of progesterone supplementation. And therefore we changed our habits, and retrospectively we compared these both strategies, and we showed no difference in outcomes between blastocyst transfer on the 6th or 7th day. So neither there is difference between 5, 6, or 7 days. So probably we have a larger window in which we can transfer blastocysts in an HRT cycle. But remarkable was the subgroup analysis which was done in this study, where we did an extra subgroup analysis comparing day 5 and day 6 embryos, and we showed that the clinical miscarriage rate of day 6 embryos transferred on the 6th day of progesterone supplementation was much higher. So this needs to be studied further to see if day 5 and day 6 embryos can have the same window of implantation and can be considered as the same blastocyst, which needs to be transferred on the same moment. That needs to be studied further. And then progesterone dosing on the day of ET is also something that becomes more and more popular after this study of Labarta, showing that when the progesterone the day of transfer is less than 9.2 nanograms per ml, that there the outcomes were worse. They are now performing a study to see if in this case they higher the progesterone dose, if that will lead to better outcomes, or maybe in the future we need to cancel cycles if the progesterone concentration is not good at the day of transfer. So that leads me to the last slide and to end with some conclusions. So progesterone is crucial for implantation and early pregnancy maintenance. Luteal phase support is necessary in GnRH agonist and antagonist protocols. It needs to start at the latest 3 days after oocyte retrieval, and there is certainly in general practice some controversy regarding stopping luteal phase support. Vaginal progesterone is worldwide the most used luteal phase support, and oral progesterone can maybe offer in the future a more patient-friendly administration route. In frozen embryo transfer cycles, HRT progesterone supplementation is mandatory and should start at the theoretical day or the day after oocyte retrieval. And progesterone supplementation in natural cycles is probably only useful when there is a suspicion of a luteal phase defect. Thank you very much.
So thank you very much, Caroline, for a very interesting presentation. I'm sure that we learned a lot from this presentation, which we are very thankful. We have a couple of questions here, several questions that I try to summarize because they are all running the same topic. And first of all, people would like to know how long in your center you support the luteal phase when the patient's becoming pregnant, and why?
Yes. We are supporting, so in IVF, in fresh IVF cycles, we are supporting until 7 weeks of pregnancy, and then we decrease with a step-down model until 8 weeks, so we stop completely at 8 weeks. And then in frozen embryo transfer cycles, we continue until 8 weeks, and then we step down, and then we completely stop at 9 weeks. Why? Good question. Indeed, we see that that from studies that we can stop from the moment that a positive HCG test is encountered. But I think we also have a little bit this luteal placental shift in mind, and I think we want to keep this 7 to 8 weeks goal in mind in order to, as Liu said very nicely in his study, better safe than sorry, and not to stop too early and to encounter afterwards that we stopped too early.
Okay, the other question is about the serum level of progesterone that we can still measure in the serum if it's possible with the different compounds. So first, why do we need such a high level of progesterone? Because is there any implication for high level of progesterone on the endometrium versus gland and the stroma? And are we using the same high dose progesterone that we are supplementing in frozen embryo transfer too?
Well, in our center, so we our dose for frozen embryo transfer and fresh IVF cycles is different. So in fresh cycles, we supplement with 600 milligrams a day. So micronized vaginal progesterone we are using in our center, and for HRT cycles in frozen embryo transfer, we are using 800 milligrams. We have changed this policy of going to 800 milligrams in frozen embryo transfer cycles last year. We want to do a retrospective study to see if it makes a difference to go from 600 to 800. I think it's a very good question to ask. Do we really need this high concentration of progesterone? I think there is a lack of good RCTs which are comparing different dosing of progesterone supplementation. So I think it's a big gap, and I think everybody follows a little bit the same rules without really knowing if this high dose is necessary.
Okay. Thank you very much again for your presentation. And with your permission, we post your email address on the last slides of the presentation. So if people will have any question, they will be able to approach you in the next 48 hours. So again, thank you very much.
It's perfect. Thank you very much. It was very nice.